In this video, we will discuss microscopic colitis, a condition characterized by chronic watery diarrhea and inflammation in the colon. We will cover its clinical differentiation, pathogenesis, diagnostic evaluation, treatment options, and current research. By the end, you will have a comprehensive understanding of microscopic colitis. Collagenous colitis and lymphocytic colitis have similar symptoms but differ in certain ways. They are characterized by thickened collagen or lymphocytic infiltration. The prevalence of microscopic colitis varies, and autoimmune factors, genetics, and environment can contribute. Symptoms include chronic diarrhea, pain, and weight loss, but lymphocytic colitis may have more frequent and nighttime diarrhea. Additionally, extraintestinal symptoms like joint pain, muscle pain, fatigue, and skin disorders can occur. Recognizing these differences is important for treatment and management. Microscopic colitis involves inflammation of the colon due to various factors. Inflammatory substances like cytokines contribute to the condition, as do autoimmune factors and certain genetic variations. Environmental triggers, such as medications and infections, may also play a role. Further research is needed for better understanding and targeted treatments. Microscopic colitis can present with chronic non-bloody diarrhea, abdominal pain, and nocturnal diarrhea. Weight loss may occur in severe cases. Malabsorption signs such as anemia and electrolyte imbalances can be present, along with extraintestinal symptoms like arthralgia, myalgia, and fatigue. Recognition of these symptoms is crucial for diagnosis. The diagnostic evaluation of microscopic colitis involves colonoscopy to examine the colon and obtain mucosal biopsies for histopathological examination. Other causes of chronic diarrhea should be ruled out. Accurate diagnosis is essential for proper treatment. Histopathological examination plays a central role in the diagnosis of microscopic colitis. In lymphocytic colitis, the colonic mucosa demonstrates increased intraepithelial lymphocytes, typically exceeding 20 lymphocytes per 100 surface epithelial cells. The lamina propria may also show mild to moderate chronic inflammation, including lymphoplasmacytic infiltrates. In collagenous colitis, characteristic features include a thickened subepithelial collagen layer, which is defined as greater than 10 m in thickness. The lamina propria of collagenous colitis may also exhibit variable degrees of chronic inflammation. The identification of these histopathological findings, coupled with the clinical presentation and exclusion of other causes, allows for the definitive diagnosis of microscopic colitis. It is important for pathologists and gastroenterologists to collaborate closely to accurately interpret the histopathological findings and ensure appropriate management. Differentiating microscopic colitis from other inflammatory bowel diseases, like Crohn's disease and ulcerative colitis, can be difficult due to similar symptoms. However, certain distinguishing features, such as inflammation patterns and distribution, can help in diagnosis and treatment. The treatment of microscopic colitis involves dietary changes and medication. Avoiding trigger foods and following a balanced diet with fiber can help relieve symptoms. Budesonide is the first-line medication, reducing inflammation and improving symptoms. Mesalamine is an alternative option. Other medications can provide relief. Most patients respond well to treatment, but long-term management requires personalized plans and monitoring. Microscopic colitis is a chronic condition, but most patients can achieve symptom control and remission with appropriate treatment. Complications are rare but include strictures, perforation, and colorectal neoplasia. Regular surveillance colonoscopies may be necessary for high-risk patients. Disease recurrence is possible, requiring long-term follow-up and proactive management. Advancements in diagnostic techniques have expanded the tools available for the diagnosis and monitoring of microscopic colitis. Non-invasive biomarkers, such as fecal calprotectin, have shown promise in differentiating between microscopic colitis and other causes of chronic diarrhea. Fecal calprotectin is an indicator of neutrophilic inflammation and can help assess disease activity in microscopic colitis. Additionally, serological tests targeting specific autoantibodies associated with microscopic colitis, such as antineutrophil cytoplasmic antibodies, ANCAs, may also aid in diagnosis and monitoring. These emerging diagnostic advances offer the potential for less invasive and more efficient diagnostic approaches, reducing the need for invasive procedures and histopathological examination. Further research is needed to validate their utility and establish standardized protocols for their incorporation into routine clinical practice. In refractory microscopic colitis, immunomodulatory therapies like immunosuppressive agents, azathioprine, immunomodulatory drugs, methotrexate, and biologics, infliximab, vedolizumab, are potential treatment options, offering a more personalized approach. Although evidence is limited, they have shown efficacy in inducing and maintaining remission. Further research is needed. Managing microscopic colitis in elderly patients, pregnant women, and those with concurrent autoimmune disorders presents unique challenges. Careful consideration of individualized treatment approaches, collaboration with specialists, and awareness of potential risks and interactions are crucial for optimal outcomes in these special populations. Research into microscopic colitis is increasing our understanding of the condition and driving progress in diagnosis and management. Ongoing investigations are focused on unraveling its causes, including the role of specific inflammatory mediators and immune dysregulation. Molecular markers, such as gene expression profiles and microRNA signatures, are being explored as potential tools for diagnosis and prognosis. Targeted therapies aimed at specific inflammatory pathways are being developed to improve treatment response rates and reduce side effects. Genetic research may also reveal new susceptibility genes and shed light on the underlying mechanisms of microscopic colitis. Collaboration, advanced techniques, and patient-centered research hold promise in improving diagnosis, treatment, and outcomes in microscopic colitis. In conclusion, understanding the different types of microscopic colitis, recognizing the clinical signs, conducting appropriate diagnostic evaluations, and implementing dietary and pharmacological treatments can effectively manage patients. Ongoing research offers hope for improving diagnosis and optimizing treatment outcomes.